Hi, everyone. Welcome to day one of the Global Digital Health Forum. Today, we'll be opening for you with a plenary discussion on the top 5 challenges in digital health today. You've just heard from our keynote speaker from the WHO about the global perspective, the opportunities that exist with better data, intelligent decision-making, intelligent analytics. But what I'm really excited for this year is to hear also from the other side of that equation. Today, we have a lineup of great speakers speaking from the country levels. Let's talk about what's happening in reality on the ground. And let's hear from the people whose job it is to actually run those health systems within the Ministry of Health, the ones that are working on the day-to-day effort of managing people and running hospitals and delivering healthcare and trying to inject these innovations, these analytics that we're talking about into those systems. As we're coming off some of the opportunities and the way forward that the WHO has presented, let's hear from these speakers that we've prepared for you today. We have speakers today from Uganda, Kenya, Laos, and Bhutan that'll be speaking about very specific interventions that they've done and highlighting the key challenges that they face with digital health today. In the next hour that we have ahead of us, we're going to begin with a series of introductions and opening remarks. We'll go around to each of the speakers, and they'll talk about the reality and the challenges of what's happening with digital health and what are the challenges that are top of mind for them in rolling out these solutions. As they go around, I would encourage each of you that are watching this plenary today to engage with the chat that we have. Introduce yourself, where you're coming from, highlight which of these challenges that we're talking about you find the most interesting. Which one do you want to discuss more? Which ones have you encountered yourself and you want to share with some of the other people that are attending this plenary? This is for your own chance to exchange with others that are attending this plenary, but this will also allow us to pick the ones that are most engaging for each of you. And then at the end of today's plenary, we'll have our speakers gather to discuss the specific challenge that you've highlighted in the chat forum and how we can turn that particular challenge into an opportunity in digital and global health going forward. With that, let's get started with introductions. First off, for myself, my name is Rowena. I'm host of the podcast, Aid Evolved. I'm the global head of digital and technology for the 45 country offices of Action Aid, a nonprofit working to end poverty. And I have another hat where I'm acting on secondment from my role as Chief Services Officer of Damagi. I'll be moderating the session today. Our first speaker that I'll welcome for you is Garib Dorji. Garib is the Chief ICT Officer for the Ministry of Health in Bhutan. He wears many different roles in this capacity. Among others, he is the chair of the National eHealth Technical Working Group. He is the project director of ePIS, which is the Electronic Patient Information Systems project. And notably, recently, some of his major achievements include his working on eHealth solutions for the COVID-19 pandemic, contact tracing, surveillance, vaccination, etc. He's also pioneered the first government mobile application for the delivery of public services to its population. You could imagine how tricky that is, getting these smartphone applications into the hands of the average citizen. Welcome, Garib. I'm looking forward to hearing from you and your challenges with digital health today. Garib, I think you're muted at the moment, so I don't actually hear you. Just unclick. There you go.
Good evening to everybody, and thank you so much, Rowena, for the nice introduction. And it's evening here in Bhutan. Just to kickstart, because we have short of time, our challenges from Bhutan we are facing while implementing is we have a lot of things in place, but at the same time, I'm sure everybody might have the same common challenges that we might discuss. But for Bhutan, governance is a challenge, resource is a challenge, and also the environment is a challenge. We today, amongst the panelists, we have from different countries have different challenges. So for Bhutan, governance is challenged because we have put systems in place, we have strategies in place, we have policies, we have adopted standards, but because our governance is poor, and we feel that we have a long way to go in terms of addressing this challenge in terms of governance, where resources are hard to get because we don't have good governance in place. Priorities are different because Bhutan is a developing country. So for Bhutan, let's say health or getting doctors in the hospitals are priority compared to the putting a system and implementing it wholesomely. We do get inadequate resources. We get projects, but it is not end-to-end support that we get to implement it with 3 to 5 year, where in between project fails because there are no good governance in Bhutan. I'll keep it to this for the moment. Thank you.
Garib, that's quite the teaser for some of the challenges that you faced. I was wondering, could you just elaborate a little bit, particularly on the governance question, which is key in terms of balancing some of those different trade-offs and priorities? What are some trade-offs that you've needed to make, or that you're even struggling with now in terms of balancing priorities that you need a good governance structure in place to do?
So if you look at the criteria for implementing, adopting, or embracing e-health, we have a lot of factors. So amongst the many factors, Bhutan has a very good e-government architecture in place. We have also been able to put e-health enterprise architecture in place. And in terms of system and infrastructure, we are doing fairly good. If you talk in terms of coverage, Bhutan has over 80% network coverage. Everybody has a mobile phone in hand. Connectivity is good. System implementation has not been much of a challenge. Also, during this pandemic, we have seamlessly been able to implement systems for surveillance, for vaccination, so we did not have much challenge. But you mentioned about the EPIS project, which is the flagship project for Bhutan for health sector, because many of the hospitals in Bhutan, none of the hospitals in Bhutan has an HIS system or a medical record system. So everything is being right now populated on Excel and Google Sheet. And we are trying to overhaul that with a major system, a standardized system, whole of country. So we're trying to do something different, which many countries are facing challenge. But this entails a huge resource. So for me, the resource comes if there is a commitment from the governance. So we have the structural governance in place, but we are not getting the funds for implementation of the project adequately. We are not getting manpower. We can't buy equipments. Therefore, there was a delay, and now because of the pandemic, we have to buy equipments with escalated price. So with that, I feel the root of the problem is the governance. If we have a very strong governance, we should be not facing a lot of challenges. The other challenges might be not an issue, I feel. Thank you.
Right. I hear what you're saying. And on the one hand, there's an incredible opportunity with the 80% network coverage, with the access to smartphones, with the work that you've already led yourself in terms of providing these mobile apps to citizens for public service delivery. On the other hand, there isn't that leadership in place to drive forward some of the digital health interventions like EPIS, which could make a difference in the health system. And so there's something about bringing those pieces together and taking advantage of the opportunity, which is the next step that you're pushing forward in Bhutan. Thank you so much, Garib. Next up, we'll be hearing from Dr. Chansali Pamavong. Dr. Chansali Pamavong is Deputy Director of Planning and Cooperation, Deputy Director within the Planning and Cooperation Department of the Ministry of Health in Laos. As part of this, he is leading the development and implementation of the Health Information Strategy for Laos. He's working with a system that many of you listening today are familiar with, GDHF, a free open source piece of software that he's currently rolling out and managing across Laos. Dr. Chansley Pamavong, we'd love to hear from you.
Thank you, Luana. Thank you for the introduction. So I like to straight into the key challenging in Laos. Actually, I got 6 to 5 challenging, but I will talk about only 3, the top 3 challenging in Laos. So the first talking about because we are lacking of patient registry with unique ID. This is very important for us because there is no unique patient ID which is used across all program in health in Laos currently. And also there's no unique national ID which is used for the country. That's why there are existing multi-ID system for different purpose. For example, I have one card for the bank, another card for the insurance, another card for the for the staff. They have many ID. I don't know what in Laos how we can solve the problem. Another problem related to the unique ID is also because the Lao name is not uniform spell out, so that many people use the nickname and widely, and this is challenging to us for use we could identify in the individual. This also caused enormous challenging in further digital health, particularly in developing hospital information system (EMR). If you have if you don't have unique ID in place, very difficult for us. Also, recently we are also implementing DHS2 for the COVID-19. Also very difficult to make a decision for that. So the second challenging for us is lack of the health ICT workforce, meaning that we have limited digital health capacity in all levels, also in the central level, even though it is at the central level, because the medical informatics is neglected in area in health with limited scope of the development. In many digital health technical staff, even at the central level, is contractual, supported by different partners. First of all, I'm managing the World Bank project, so I hire about 6 to 7 IT staff to support the implementation of the DSS2. But there's none of them is government. How we can make it more sustainable or more long-term capacity in Laos? We are facing that one. Also, the lack of plan when we will build the capacity within the Ministry of Health, within the government budget, because more we are relying on the development partner support, donor support, ADB, World Bank, and other UNICEF, other things support the staff. And the last one is very similar to the Bhutan on the governance. There is no clear governance structure on digital health development within the Ministry of Health that has oversight. Also, each department have managed its own digital development project within limited coordination within Ministry of Health and among development partner supporting Ministry of Health. Also, the Ministry of Health has currently restructuring, meaning that we are going to, actually the health information unit belong to the DPC, our Department of Planning Coordination within our unit. Now the Ministry of Health want to scaling up. We will build a new health information center, but it is not clear which belong. Maybe it belong to the cabinet, belong to other department, not our department at all. I think this is also challenging for us because the investment, more investment is given to our department, the planning department. But then when we build a new health center, a new center for the information, we need to start. We don't start from the beginning, but we need to invest a lot of. Also, we are not clear about role and responsibility, because we have Also, we call the Ministry of Technology and Communication, which is outside the Ministry of Health. They also managing the digital technology, so we need to work with them. But I don't know what is the role they will play. Actually, we leave our server within that department, within that ministry, but it's not functioning, and then we move to cloud server. Now cloud server more functioning, but they require us to bring back to the country. It is also challenging for us. So this is the main challenge in Laos, but I'd like to emphasize on the first order. The unique ID for Laos is we cannot do anything if we don't have a unique ID. So this is my challenging in Laos. So thank you. Over to you.
Thank you, Sally, for your various comments and for the depth that you've provided on them. I'd love to hear more about this unique ID issue that you're pointing out. I mean, surely it's not just a health issue. Surely in social services, in financial services, and a variety of government services, there's some cross-cutting desire from the government to issue a unique ID. How is it that this has become so front of mind for the Ministry of Health to champion, and how does that play out in terms of navigating the relationships that you need to navigate with others in government?
Yes, thank you for the question. Because we also other ministry like Ministry of Home Affairs, they also starting to think about how we can make a unique ID, but it's just starting. They are just only piloting in 1 or 2 provinces. So because of we health sector is needed, so we need to start now. So under the support from other partner, we implement which we call the family folder. Meaning that we just make a household survey, and we got all the name and the family name put in the electronic, put in this, so use tracker within the DSR2. So we have now information, but we need to matching with the Ministry of Planning, and they call the Statistic Bureau. They also have the same data. We also have MOHA or Home Affairs. We also need to matching this. Even though we propose them, if they don't have information, we can use the health, but we need to discuss more about it. We need to talk to each other in the higher level, so that we can have sort it out the unique ID for Lao citizen, for across cutting sector on finance. I mean, because everyone have its own. I have, as I said, I have one bank account, another ID for the insurance, different thing. I don't know. I also want to learn from other country how they can solve this problem in the country. Thank you.
Thank you, Dr. Sally. It's a tough one for sure. And if you are able to build those bridges with other ministries, let us know. I think many countries with much more resources have failed in that effort. But it is interesting just seeing the opportunity that exists with you to consolidate your indicators, to provide continuity of patient care with that unique ID, and also just to recognize how useful such infrastructure is for a variety of government services. And also just to note the ethical considerations that are involved in government rollout of a unique ID. But we'll see if we get time to discuss that more in our discussion session of this plenary. Just before I switch over to our next speaker, I'm going to give another shout out to our listeners to, again, put in your comments in the chat about what you think about these different challenges that are being raised. What do you want to hear more? What do you want to see us discuss the opportunity to turn these obstacles into opportunities? And then that'll shape our discussion towards the end of this plenary. Next up, I'm thrilled to welcome Alan Maleche. He's joining us from Kenya. He is an activist, a human rights defender, an advocate of the High Court of Kenya. If you look him up on YouTube, you can see him right in the thick of his protests, leading the way for health rights and human rights. He's the executive director of the Kenya Legal and Ethical Issues Network on HIV and AIDS, that's KELIN, and he co-chairs the UNAIDS Human Rights Reference Group. Lastly, but not least, he is a former board member of the Developing Country NGO delegation to the Global Fund Board. So clearly this man has worn many different hats that are relevant to our digital health work. Welcome, Alan. Let us hear from you, your challenges.
Thank you for the warm introduction and setting the expectations so high for the participants. I hope I'll be able to meet them. But Rowan, I think building up to the experiences of the two colleagues from Bhutan and Laos, I think for us who work closely with affected communities, health service users, the number one challenge we've seen, and this coming from a backdrop of a landscape analysis we have done with the support of Transform Health in Kenya, the one thing that's coming up for us is that there's a gap in the laws and policies, at least for Kenya, with regards to regulating digital health, the use of artificial intelligence, and digital technologies in provision of healthcare services. So the gap around the legal and policy framework is a gap that speaks to the fact that technology is moving faster than parliamentarians could be able to regulate or governments would be able to put policies in place. And so there are things that are moving so fast that you don't have a legal framework to be able to guide what should happen or what should not be able to happen. That's a growing challenge that we see because governments, private sector, civil society, especially with COVID, everyone is embracing the use of technology. But when issues arise, and which brings to my second concern, the second biggest concern is around privacy and confidentiality, because you're collecting personal information relating to one's health status, in some cases, one that is unique to a specific people, unique to a specific group of people. And in a number of countries, you've got groups of people who are in conflict with the law and may not want to easily give their data to governments or to private individuals or to donors. So drawing that balance, people have the fear that if I give information about my HIV status, if I give information about my COVID status, if I give information about something around genetic, where is it kept? Who is holding it? And what happens if it gets to the hands of a third party? That remains a growing concern. And the third concern that has been slowly popping up that stems from the legal and policy framework is the concern of the data that is collected. Who actually owns it? Is it the government? Is it me who gave the data? How do I have access to it? And what happens to the data? And I think that all becomes a growing concern. So those are the top three things, but I just want to throw in one more thing that is not unique to Kenya only, but unique in many areas in sub-Saharan Africa around the digital divide. There are many people in rural areas who have no access to electricity, whose internet connection is not great. And so the joys of telecounseling, telemedicine, speaking to your physician on Zoom, that becomes a luxury that is not available to them. And so the fact that there's a large digital divide, despite the fact that many people have got access to cell phones, then continues to promote that inequity and inequality in terms of access to healthcare services that are of good quality. So I think in a nutshell, everything for us and from the experience we've had in Kenya derives from the fact that when you don't have a clear legal and policy framework that people understand, that people know how to use, then it creates hesitancy to certain groups of people to want to uptake the use of digital technologies or health programs that would eventually advance the enjoyment of the right to health. I'll pause there and I will come back to the conversation later, hopefully with thoughts on how we can move this forward. Back to you, Rowena.
Thank you, Alan. A lot of key thoughts that you've pulled out there. One in particular that really resonated with me is about this question of data ownership and who owns the data. As you said, is it government? Is it people? I was just interviewing Dr. Rajasekharan from Jacaranda Health, and he mentioned how there's such a high uncertainty around what do we do with this data, both in the nonprofit space, but also in many governments. It's not like we've set up the systems for a lot of government actors to have a clear policy decision and training around who owns the data. So I think that's a very pertinent question. Alan, do you have any guidance on how these front-running policies get made? Part of the challenge, as you know, is that you mentioned AI. AI is evolving every day, and there's only so many people that can walk the front lines of legal and policy and digital like yourself. So what is the way forward for coming up with policy that protects rights without being overly prescriptive, the way that, recognizing that in some ways, innovation is going to run a step ahead, as it always does?
I think that's what every country, at least in Sub-Saharan Africa, where we worked a lot, is grappling with. I think the EU and others are lucky to have strong data protection laws. But based on our HIV experience, I think the only way to get a good law and a good policy is one that involves consultation with the users, with the affected communities, with those who are implementing. So when you have a variety of stakeholders and you're driving a good consultative process, you'll be able to draw the balances and where the trade-offs have to be given, where rights have to be safeguarded, but also where the use of technology can be seen and can be used to be able to promote access to the right to health. So I think it largely beholds on our legislators in parliament, so in Senate, those who are working at the executive level in the ministries of health, in the ministries of ICT. It requires that close partnership and coordination and structuring ways to have these consultative forums and working with people to adopt the laws and the policies. And once those are adopted, doing a lot of education about them so that people know about them and they're just not there, and people can know when and how to use them, because it will instill confidence in people to say, I know now where my data is kept. I know if it's breached, this is what is going to happen. I know this is a process that needs to be explained to me. So it buys confidence. And so to all the parliamentarians or those in the executive or those who are responsible with lawmaking, then they need to bring the communities and the affected people on board in developing of these policies and laws so that they are reflective of the actual needs, and then being open to amendments depending on how fast things move and what challenges and opportunities that are brought with the use of digital technologies. Back to you.
That makes sense. Government, like everyone else, needs to be adaptive to the changes that we see in the world. Last but not least, it is my honor to welcome to the stage Carol Kamasaka. Carol is president of the Uganda Health Informatics Association, and she has a unique role to play in that she has worked very closely within Ministry of Health at the national and subnational level, and she's also worked as an implementer on various different projects with so many different organizations. I'm not even going to name them all, but she's spent over a decade working in digital health at all levels within Uganda. So she can speak from a very practical perspective of what are the top challenges that we're facing for digital health in Uganda. Welcome, Carol.
Thank you, Rowena. Good morning and good afternoon, everyone. I'm very delighted to be here and to be speaking about the challenges we are facing in the country in trying to implement digital health solutions. And I think some of these challenges, it's taken us implementation of digital health solutions to realize that we have these challenges in the country. Our biggest challenge is the lack of capacity of our health workers at all levels. I mean, I'm talking about health workers in the health facilities, health workers at subnational and national level, the lack of capacity to use the digital health tools, but also the hardware on which these digital health tools sit. The lack of the even basic ICT skills to use computers, to use mobile devices like tablets and phones. I mean, these are the last mile people who are going to implement these digital solutions, the ones that are going to use them on a daily basis to see the patients. But along the way, we realized there's really a big gap in terms of ICT skills of these, our health workers. So right now, that is our biggest challenge that we are grappling with. And in trying to implement digital solutions specifically for
we cannot
COVID.
hear you.
Can you hear me?
I can hear you, Carol.
Okay.
Sorry.
Okay.
Yeah.
Okay now.
All right. I think COVID came in as an opportunity for us to implement digital health solutions, but these are some of the challenges we are facing. The other challenge is related to infrastructure. There's inadequate infrastructure in terms of networks, internet connectivity, in terms of power. We have areas in the country that do not have power at all. They do not have internet connectivity at all, but also hardware itself. Implementation of digital health is a hardware intense activity, and its investment in hardware is really heavy. So we have a challenge in terms of that hardware to support implementation of our digital health solutions. And then the other challenge is we have quite a number of donors, implementing partners, development partners, and their investment plans in terms of digital health are quite different, and also different from the national plans. So there's a bit of uncoordination in terms of investment into digital health. And because of that, we find ourselves having multiple partners investing in the same area, investing in the same solutions. So that uncoordination actually leads to wastage in resources. It brings a burden to our health workers in terms of the tools that they're implementing, but also it presents implementation of digital solutions that are not sustainable. Lastly, the lack of standards and guidelines to guide implementation of our digital health solutions. And we normally say that we built our city without a plan, and now we are trying to put a plan in place to organize our city. But I mean, we are not going to break buildings in trying to put this plan in place. A few would be broken. We have to really harmonize. I know there are standards and guidelines from WHO, which we are trying to adapt and customize for our country. But that lack of standards and guidelines is a huge challenge to us. Thank you. Over to you, Rowena.
Thank you, Carol, for these pertinent topics. One follow-up question I had from you was on this coordination of investment plans. As you know, Uganda has seen a host of different interventions, and the government has taken some very strong and laudable measures in order to enforce and encourage coordination. Can you talk about your experience with this? Maybe a specific example of where this lack of coordination is evident in your work, or an example of where you've seen it happen well, where two quite different funding streams came together and did something in alignment with ministry interests, and practically how did that work better than all the other ones that don't work that way?
Thanks, Rowena. It's very interesting that the current national plan aligns to digital transformation. And because it is a national plan, it's a national development plan. So we have seen our partners and donors trying to align to the national development plan in terms of digital transformation. And with that, we hope to see some bit of change in coordination. Our partners range from the UN partners, we have donors from the Global Fund. So all these partners and donors are trying to fit into the national strategies, the national plans, but also the health sector strategies. And this is a journey that we've just started on, because the country realizing that, yeah, there's a digital transformation and we need to actually move with the transformation, and then having our partners align to it. Yeah.
That makes sense, Carol. Noting the need for coherence, that's one of the reasons why the government put together a digital strategy in the first place. And many governments don't have that, but Uganda does. And because it does, then the donors can review it. They can coordinate amongst themselves. I'll fund this part, you'll fund that part. And then the pieces come together. I'm sure it doesn't work so smoothly all the time, but at least it's a step in the right direction. We had a great comment from Mercy in the chat, who noted that, yes, these are all the challenges. We know these challenges. Let's talk about solutions. So and this is Carol, this isn't just for you. We'll switch over to anyone that wants to dive in on this particular discussion point. So moving on to the second half of our discussion, talking about solutions. One theme that has come up several times, both in the speaker comments as well as in the chat comments, is governance. This willpower for change. How does it happen? How do we build that movement, that momentum, that decision-making authority? I'd love to hear from our panelists, our plenary participants, some context about what digital health governance looks like in your country. Who is it that actually makes the decision to go or not go with the next shiny thing that comes along? Or what are the bodies that come together to make that decision? What's working and what still needs work in your particular country context?
Rowena, can I go first?
Yes, by all means, Carol.
Okay, thank you. For the case of Uganda, there are quite a number of regulatory bodies in place, and this digital transformation and the whole change to use of ICT is now a collaborative effort. We have the Ministry of Health, we have the Ministry of ICT, we have regulatory bodies that are in charge of regulating internet, regulating these digital solutions that come into the country. So for us, it is a whole multi-sector collaborative effort to ensure that sectors are not moving on their own, but also to reduce on the duplication. We don't want an entity working on, let's say, laying the backbone for the country, and then another entity is not aware of it and they're looking for resources to build one. So we have, if there's an entity that is laying the national backbone for the country, we leverage on that, other sectors leverage on that. So it's a whole multi-sector collaborative effort. And I believe for us, that is an opportunity as a country to grow and also harmonize the synergies in implementing digital health solutions.
Thank you, Carol. Excellent points. And I'll also add, I think it's this question of how we move forward. I know it's one that many of you wrestle with every day. I was listening to the former Minister of Finance from Guinea, and she was saying how externally, it seems like we spend a lot of time working with government to move things forward, but internally in government, it's so much more. It's the same. And so as each of you is pushing for change in your own way, if there are any tactics that you've used, to bring the right people to the table at the right time, it's so easy to say like everyone should be involved right from the start all the time. But as you know, resources are limited. So if there's any tips you can throw in about how we do this right, or drop the things that we don't need to get done. Would any of our other panelists like to speak on this topic of governance and governance in action? Alan, I see your head nodding.
Yes.
So I think the whole issue around governance involves the whole issue of participation and consultation and decision making. So I think in terms of participation, there must be deliberate effort to listen to all voices of the users of the digital technologies, the implementers. And so key to that is the participation brings buy-in and ensures that people are able to take on board. Even if a donor comes with a flashy toy of form of digital technologies, there needs to be consultation so that the people agree or disagree whether it works for them. And that makes it much more easier for the government not to feel pressured to take forward digital technologies or artificial intelligence that may not be helpful to the situation. So I think consulting with the affected communities, consulting with healthcare workers who are expected to roll out some of these digital technologies. Sometimes those in public hospitals already have a large workload. I think it's important. So for me, in terms of governance, is one, the participation, but also setting up multi-stakeholder structures that allow different stakeholders from ICT, from health, from information, from data protection, to sit around the table and look at the issue from a holistic perspective, rather than leaving it all from one party or one ministry or one sector to be able to do it. That multi-stakeholder engagement is extremely critical if we want to scale up and make the governance process strong enough. Over.
Absolutely. And it's a fine skill, convening all those different actors and getting them to agree on the way forward. Sally, I know you've had your hand up for a little while. Would you like to go next on the governance topic?
Yes, I think so. Yeah, because we also facing the problem of governance in our country when we implementing the COVID-19 data, because the Ministry of Technology and Communication also want to do that. They also want to produce the QR code for the vaccine. Ministry of Health also want to have a QR code, which is because of we don't have a governance in place. We don't have, so that's why we need to have at least. I really agree that we need to have a strong coordination between different ministries. Otherwise, we will have a big problem when we scaling up the digital technology in our country, because we need to have a unified system that can every ministry can apply to use. That's why I really support that governance is more important in the digital health technology. Thank you.
Thank you, Sally. Gareb, over to you.
Thank you. I would also like to add to the first two speakers on the governance. I feel the solution to the root cause of all these challenges we talked about in terms of challenges of health workforce not being able to adopt technology, infrastructure, then we have discussed about, Dr. Chancellor mentioned about connectivity and ID, I feel what Bhutan has been doing is to compare it to what our Minister of Health has been doing, because Minister of Health, Bhutan has a free healthcare service, so we don't have health insurance system. So the health financing is very challenging in Bhutan. And therefore, what the Ministry of Health is moving, our Prime Minister is a doctor as well. So the new doctor-led government is doing is they're trying to reform that into securing the health financing by putting it into the constitution that certain percentage of the national revenue should be allocated, larger revenue should be allocated to the health financing. In a similar manner, I feel it should be seen for the technology. In terms of, as I mentioned earlier, in terms of technology adoption, infrastructure, softwares, we don't have problem. And Jaya has also some comments on the system, but collaboration with NGOs and international agencies, we have no issues with that. The outcomes are beautiful, and a lot of results have been come out as a result of all this collaboration. But because we don't have a commitment from the governance, I feel the other issues are evolving from that, because we don't have if we have in the act, in the Health Act or in the National Constitution, where the chapter on financing on the technology e-health, then I think all these problems might be resolved. Thank you.
Thank you, Gareb, for pointing to those questions. And actually having a prime minister who's also a medical doctor, that's got to be, in terms of leadership, that's got to stand for something. So it's interesting to hear that you still, even that isn't enough. You still need to go through the appropriate steps. You need to look at the Constitution. You need to put the appropriate decision-making in place, even though at the very top, there's an appetite for this kind of work and for moving the agenda forward on this kind of work. We have a question for all the panelists that came up in the chat, and it's specifically looking at public-private partnerships and the role that plays in digital health initiatives in low and middle income countries. I think this is kind of a cross-cutting issue, since public-private partnership can play a role in a lot of different ways. But I think in terms of the constraints that we've talked about a lot, resource constraints and the kinds of resources and capacities and assets that the private sector can bring in is obviously something that we look at all the time. Could each of you speak to what public-private partnership looks like in your country? What are the attributes that have been most compelling or interesting? What are the instances, if you can think of one, where it made sense for your ministry to engage in a specific partnership, and what led to that kind of public-private partnership?
Thanks, Rowena. I'll go first.
That's good.
That is actually quite an interesting question, because I'm looking at the private sector. I'm talking for the case of Uganda. The private sector has been implementing these digital health solutions, and it gives us an opportunity to not just work with them, but to leverage on those solutions, build on them, and bring them to the public sector. Although most of these solutions are not open source solutions, but through various conversations and stakeholder engagements, we can have some of these solutions opened up. I know for our case, we have had one of the private innovators come to us and have partner with them and the Ministry of Health to open up their software for the public sector. It's called Clinic Master. Yeah, it's called Clinic Master. Yeah, it's been implemented in the private sector largely. And it came at a point where we were trying to build an open HIM for exchanging data from the EMRs through the lab systems for viral load. And it created an opportunity for us to partner with the private sector and have these donors come in and see how they can support the private solutions to support the public sector. So I think those are some of the advantages we have with the private sector, conversations and engaging the donors to see how we can have these solutions leveraged on. Thank you.
Thanks, Carol. That's a great example, particularly since you don't often see examples of a closed source intellectual property retaining solution in the private sector move over to an open source public good. I can imagine there's all sorts of discussions that need to be had around price point and revenue model and commitment to using the platform in order to make such a thing possible. But clearly it is. And then clearly you can take some pieces that come from the private sector that arose from that innovation, and then, as you say, spread it out within the public sector. Does anyone else? Alan, would you like to go next? Looking at public-private partnerships?
I'd say private-public partnerships are extremely important, and gladly the Kenyan context, we already have a legal framework that governs them. And that is a good way to start off, because existing laws on private-public partnerships are extremely important. But I think the things we have to clarify within public-private partnerships is, one, they should not operate to the exclusion of any community or any particular person in that particular response. They should be more inclusive. Sometimes, from my experience, they're more geared between a private company conversation and the government to the exclusion of some of the affected communities, and sometimes that can be problematic. And so we should safely guard to ensure that private-public partnerships do also get subjected to the same standards that other public services and interventions are going through that involve citizens' participation, health users' participation, and for them to be able to give their views around going this, and also ensuring that whatever initiatives they're putting in place are in line with the country's laws and policies, and that they respect human rights.
Absolutely, Alan. There you are, defending human rights as you do. Garab or Saleh, are there examples? And if there isn't one that's top of mind for you, that's totally fine. But are there examples that you can think of public-private partnerships that have worked well for you in addressing some of these challenges?
In Bhutan, the private sector has just started to grow, and especially in terms of the e-health is a new thing. So they just, for instance, our vaccine system developer they have developed the system open source, and they are willing to share it publicly. So, and that is one instance I can share. But other than that, our IT sector is just growing and has been more of a commercial. So, in terms of sustainability, in the past, for instance, Bhutan has been getting a lot of support for DHIS too. So, globally, they have HIPs across the globe in every country, many countries. But in Bhutan, we don't have. So, we have been taking support from Indian HIPs India or any support that we need. So, there's potential to have a HIPs Bhutan whereby we could have our support just within Bhutan. So there are, what I'm trying to say, there are potentials. And right now, our private sector is not aware about the market opportunity. Thank you.
That makes sense. Sally, did you want to add anything?
Yes, I'd like to add a little bit because during the COVID-19, there is also a lot of private company requests to Ministry of Health. They also want to involve in the collecting of the COVID-19 information, and then we allow them to develop their own software on the pre-registration of the vaccine or COVID-19, pre-registration on the COVID-19 patient. But I also would like to support Alan also talking about that because this need to be linked with the national platform, linking to national DHS too. We have some problem like one private company approached the Ministry of Health. They are also develop another software that registration of the people who are vaccinated COVID-19. And then later on, we cannot link with our system. We need to, because of they even though they invest a lot of budget, but it's not used. Actually, in our Ministry of Health has already developed the same time, and when we already announced to the public that we can use, and then we cannot link these two systems together. It's one experience that I have. Thank you. Thank you.
That sounds problematic. You talk about it very quickly, but it sounds like you announced it to the public and then you couldn't link the system. Tell us more about how you manage that situation. It sounds like a tough situation to be in.
Yes, but actually because in Laos, private sector a little bit is still underground. Mainly we have a partner. I don't know, like a child, the Clinton Health Initiative. They also developed another software because the M-Supply system, also linking to our system, and other partner like a big, not private sector, but like a UNICEF, UNFPA. They also have support how we can build a partnership together within Ministry of Health. Over to you.
Thank you, Sally. We're running a little bit short on time, but let me pull out one last topic and we'll see if we can maybe get at least one or two comments on that. And that has to do with human resources and digital health capacity. I think that's something that Sally, you spoke about as well, and we've spoken about in the context of having talent, keeping talent, like going to the private sector for talent if we're looking to keep the talent in country. And obviously that's a big challenge in terms of ensuring the sustainability and the management of these digital health systems long term. Are there any opportunities to address this challenge? Is there anything that any of you have seen to really expand the space of solutions on the human resources side, be it an investment in government staff, be it looking at the private sector, or be it something else, something novel that you want to highlight as a potential solution to the human resources challenge that we have?
Yeah, I'd like to start with how we can overcome the challenging. I think we need to start thinking about how we can build a long-term staff that when they come back. So we are now talking about linking this with the National University of Health, so that we can start discussing with other in the ASEAN country, so that they can assist the country to build more capacity. So we can send our staff, the student, starting from their medical doctor. We need to send them to study on health informatics, on other things, so that, and also, especially also on the IT technology. When they come back, when they graduate, they come back, they will devote to the country, rather than we just hiring the very expensive private consultant to assist us. This is not long term. Thank you.
That's an excellent point. Investing in the health of our workforces and giving them opportunities to study wherever they need to in order to bring that capacity back to Laos. Any other comments on that human resources question from our speakers?
Maybe briefly, Rowena, I think while we are at it, while we are developing these solutions for our countries, we need to have our health workers involved, interactively developing these solutions. It gives them an opportunity to feel like they are really involved, to feel like their opinions are valued, and when it comes to using them, they can easily adopt and adapt to these solutions. But also making them comfortable with ICT, because most of them might think that, okay, these computers are here, these digital solutions are here, they're going to replace us, they're going to take away our jobs. So it's a whole mindset and attitude change, which we have to manage gradually over time, develop with them, make them comfortable with ICT, make solutions that are easy to use. And I think we'll be able to retain our health workers, and the transformation will be easier. Yeah, thank you.
Thank you, Carol. Definitely want to emphasize that there's so much effort and energy that goes into various different project staff or nonprofit staff and such, and not enough that goes into the core people that are actually running the health systems. And as these health systems evolve, they become more digital and more innovative. We also need to make sure we're investing in those individuals in training, in terms of training, yes, but in other ways as well. I was speaking to a colleague from the Ministry of Health in Ghana about how the amount that they get paid is just a tiny fraction of what they would get paid if you join some sort of nonprofit project. And so you can imagine what a challenge that makes for ministry staff who are constantly being pulled away by these nonprofit or these aid ventures whose stated mission is to serve the Ministry of Health in the first place. So there's this weird tension and dynamic there that you've really hit the nail on the head with. With that, we've unfortunately come to the end of the time that we've had. Thank you so much for all the comments in the chat. I apologize, we didn't get a chance to go to all of them, but it looks like you've had a chance to at least exchange amongst yourselves, and maybe there's some opportunity for further discussion among our participants, amongst yourselves, using the conference platform. So please take this as an opportunity to continue the dialogue. As we look forward over the next couple of days of the conference, there's many other sessions that dig into the solutions that maybe we didn't have as much time to talk about in our sessions. Tomorrow, there's one on filling the governance gap, strengthening digital health ecosystems. And Wednesday, there's one on digital health and rights, which would be a natural follow-on to the conversation that we're starting here. Thank you all so much for joining us today at the Global Digital Health Forum. Have a blast, talk to people, network, take advantage of everyone that's here. We don't get these many experts in the same room very often. And thank you for joining the plenary today.
Thank you and good evening.
Thank you.
Thank you.